But just take a short session on systematic reviews. Uh, just for an example, why should you do systematic reviews? Why not just stop with an RCT? I noticed there were many people from the Tibetan group and as well as from the Ayush and also from Cochrane. So I just taken one example: yoga to prevent heart disease. There's a systematic review of many randomized control studies looking at yoga to prevent heart disease. Now you may think that's very ridiculous, I mean, depending on your viewpoint on complementary health. How can it help? But actually, this this systematic review, you can Google this. Just Google it now. You can find the same review: yoga to prevent cardiovascular disease. It's available on the network. When if you use a Wi-Fi and password. And this was published recently. About 2 years ago, it was updated, December 2021. And if you look at the 2019 American Cardiology Society, Cardiac Society, and American Heart Association, the 2019 guidelines on primary prevention of cardiovascular disease, they've quoted this particular review. So what was done here, a Cochrane review looking at yoga to prevent cardiovascular disease. Now the review has found itself into a guideline. So anywhere in the world, WHO, people, countries all over the world use Cochrane reviews to make guidelines. Once it's in the ACC guidelines, most other countries just copy the American guidelines, cut and paste it in the Indian guidelines. So I just took out the next slide. If you look at this particular, look at this guideline, what does it say? It's in the different types of physical activity which can prevent heart disease. There you can see that yoga comes under moderate activity. Yoga contributes 3 to 5.9 meters. So active yoga comes here. People into biking, recreational swimming. I'm just saying. So they have tried to incorporate complementary, what they would call complementary into allopathic. So it is possible to do anything. Doesn't think that we cannot do studies in any particular field. It has to be only drugs. It can be educational interventions. It could be non-pharmacological interventions. Currently, there's a raging controversy because of a Cochrane review saying that masks don't work, and social distancing and lockdowns were not very effective. Of course, now it's already over. It's already left stable. Uh, this guy called Archie Cochrane, he was the first guy who sort of said that how come that we have so many treatments and so many specialties, and everybody is doing whatever they like. So basically, I can give one treatment, you can give one treatment, nobody questions it. He said, why don't we collect all the questions on one particular disease and put it together and then get some idea out of it? That is, I'm paraphrasing what Archie Cochrane said. Out of that, the first activity began in UK, the pregnancy and childbirth group. So the obstetricians here can be proud because they were the first group to put a collection of all systematic reviews in OBGYN and see what treatments worked and what treatments didn't work. And the chap who was inspired by Archie Cochrane was Ian Chalmers. And subsequently to that, he started this Cochrane collaboration in 1992. The Cochrane Center in UK began in 1992, and the Cochrane collaboration, which is a group of volunteers all over the world who do systematic reviews, they began in 1993. So when he wrote this book, he said, yeah, this is a milestone inspired by Archie Cochrane. He was knighted, it's a big deal in UK to become Sir Ian Chalmers. And he said that we usually put up a photograph of the people who do this. And he said, no, I want you to take a photo of all my collaborators in the Cochrane collaboration. So this is him taking photographs so that he said it's a collaborative effort, not really me. Just to signify that group of people working together can do a big change. So the Cochrane collaboration really looks at better health. Everybody says better health. It's like world peace and all this universe. Say, what do you want? Global peace. So it sounds a bit much, but really better health by people making better decisions based on high quality evidence. So the Cochrane's role is to give you high quality evidence. You may use it, you may not, but to provide high quality evidence to people is really the mantra of Cochrane. So you can Google this website. It's the Cochrane.org website, and Cochrane 90% of WHO guidelines now contain Cochrane reviews. There was a time about 20 years ago when there was no systematic reviews quoted in WHO guidelines. It was just a group of experts getting together literally and then over a cup of coffee deciding what the whole world should do. After a lot of criticism, now it has changed the other way. All their WHO guidelines have to have a systematic review, evidence. If there's none, they do their systematic review or commission one themselves. So systematic reviews have got into WHO guidelines, most country guidelines as well. This is the Cochrane library. It's sort of like the product of the Cochrane collaboration, which is generally free to access in CMC. To use our username and password, it's free. But in some other countries, it's free. In some other places, you can see the title and the abstract, but you can't read the full text. You may have to pay for that. So that is how they survive. Does it make a difference in any country? I've taken Denmark. In Let us say in 2014, only 20% of Denmark's guidelines had systematic reviews on evidence quoted in the country's guidelines. And by 2021, 80% of Denmark's guidelines were based on evidence, all the country's guidelines. And I mean, with the hope that all 80% of them had Cochrane systematic reviews, but about anywhere between 20 to 40% of their guidelines use Cochrane evidence. It's not that Cochrane is some gold standard of anything, any systematic review. So all of these use systematic review. Of that, roughly one third to one fourth are Cochrane reviews. Like I mentioned, the specialties, as a physician, I find it strange. Obstetrician, I wonder why is it so strange, but obstetricians use a lot of systematic reviews for their practice, and they're quite evidence-based. Next is pain and anesthesia, and then dental, and then comes many other specialties from where people use these guidelines. So people use systematic reviews in their guidelines. So this is just to give you a flavor of why it's important. If you type into the Cochrane library, it's all free for you all now. If you use the Wi-Fi type, you can search the search word in Cochrane library. If you put complementary or alternative therapy, there are 1,273 Cochrane reviews. There is systematic reviews involving alternative therapies or complementary therapy. So it's not a small part of it. So that's what interests me is useful. I just typed in yoga, and there are 54 Cochrane reviews on yoga. Yoga for asthma, yoga for epilepsy, yoga for preventing heart disease. So it is useful. If one of you is interested to search for randomized controlled studies in your area, very often I heard people saying that, oh, there are no RCTs in my area. Apologies. Yeah. Okay. So if you look at Cochrane library and where I'm standing, okay. If you look at Cochrane library and search yoga, I think I take it off. I generally don't need a mic. 4,791 randomized controlled trials. The Cochrane Library is the largest resource for randomized controlled studies on any topic. So if you're not sure if there are any RCTs done on your topic, you don't want to do a systematic review, but you just want to search for randomized controlled trials, search in the Cochrane Library. Search is free. Then you can see these, you can go to these and say, oh, I didn't know there are 4,000 trials of yoga, randomized controlled trials involving yoga. So in any specialty in the world, the Cochrane Library is the largest repository for randomized controlled studies. How to do Cochrane review? I'm going to take only a half an hour class. This book is free. Cochrane Handbook for Reviews of Intervention. So just Google Cochrane Handbook. It's free anywhere in the world. You don't have to pay money to anybody to download this. You can't download the book. There are many chapters. You can read chapter by chapter, and then you can copy and paste the whole chapter by chapter. But if you want to download the whole book, they'll charge you money. Simpler is just it's free on the net. Why do you want to waste fees by downloading and printing it? But it's really a fantastic resource. So the first thing to ask in the Cochrane review is, do you have a good question? And the question is always PICO question. Who are your patients? Who's the intervention? What's the comparison? What's the outcome? This works very well for intervention studies. It can also work for prognosis studies or cohort studies. Etiology questions like case control, diagnostic studies, qualitative studies. So previously Cochrane focused more on randomized control studies, but now it has got solutions for everything. Cochrane prognosis group, Cochrane qualitative group, Cochrane complementary group, public health group, economic group, methods group. So there's some funding issues with Cochrane, so you may find a bit of issues, but generally they have all sorts of things in Cochrane. So first thing is you must decide your PICO and your study design. So PICO, so patient intervention control outcome. T stands for time, meaning how long the patient is going to be followed up for the outcome to happen. PICO TSS is the study design. So tomorrow you must all tell us your PICO, and obviously we're hoping to do RCT because that's the workshop. And PICO T is how long the time taken for the outcome. S is the study design. Once you have determined your criteria for the PICO and the Cochrane library, or the, right, when you're doing a systematic review, then you have the search literature. But remember, you're not doing an RCT. You're searching for other people's RCT. So how to search global literature is a big science in itself. Most of us will search PubMed or Google search, but there are many, many places to search, and there's a big science of how to search. So searching literature is a big part of Cochrane library. Then once you get the results, how do you analyze the results? So you have to collect, let us say you get 20 RCTs on your topic. How do you extract the data from the 20 papers? How do you put the data together? How to analyze it? Once you analyze the results, how do you interpret and present the results? So there's also a science to interpret and present. I'm going to take you to one review. So in the interest of time, I'll just show you a review, then it will become clearer. So what are the kinds of questions one can ask when doing a systematic review? One can look at what is the value of treatment X compared with treatment Y for a particular group. What's the value of yoga versus back massage for backache? So that's two different kinds of treatments for a disease. Or what's the value of yoga for epilepsy? Yoga versus nothing. Or what's the value of physiotherapy versus nothing for backache? Most backache go away by themselves, so why should you do anything? So the title may not have all the PICO elements to it, but you can ask the question in different ways. Here's an example from Ayush. So people with mild COVID, there were 2 tablets of Ayush. There's no tablet called Ayush, but it's Ayush 64, thrice daily, versus the standard of care. That could be any of these treatments. So they could be Ayush versus paracetamol, Ayush 64 versus vitamin C, zinc, chloroquine, doxy, blah, blah. And the outcomes of clinical improvement closest to 14 days. They also looked at adverse events and looked at virus clearance. So this is an example of a PICO statement that one could have while doing a review. So if one asks what is the effectiveness, safety, and acceptability of yoga versus medical therapy for backache, what would be the study design? Cohort, case control, diagnostic, quality of life, RCT, which study design will answer this question? So because we are comparing 2 treatments, yoga versus medical therapy for backache. So when I am comparing 2 treatments, the best study design is randomized control study. So it's an intervention study or randomized control trial. There are 2 ways of asking a question. You can be very specific. Vitamin D supplementation versus no vitamin D to prevent TB. Very specific. Randomized control studies where somebody is given vitamin D, somebody doesn't get vitamin D, and the outcome is the new incidence of TB. That's called a narrow question. A broad question is treatments to prevent TB. That could include vitamin D, it could include nutrition, it could include better food, better housing, money, economic development, happiness. I mean, all sorts of things could be there to prevent TB. That's a broad question. That systematic review will be really big because it has to look at many, many interventions. If you are starting off for the first time doing a systematic review, try a narrow question. Vitamin D to prevent TB. So it's very simple. So only looking at randomized control studies which compare vitamin D versus nothing to prevent TB. So it's very easy to look at the studies and decide if you want that study or not. Once you become a little more experienced, you say, I want to look at everything for preventing TB. Then you have to look at many, many interventions. Tell me vitamin D plus exercise versus vitamin D alone. All sorts of combinations people would have studied, and your review tends to become big. So that's the first thing, narrow question or a broad question. Narrow questions are easy to read. Suppose I'm sitting in the OPD and I want to know, doctor, my uncle has TB, I'm scared. What should I do? Then I think, oh, should I do vitamin D? then I'll quickly look at this review and then it'll give or don't give. Simple answer. But that narrow question won't tell me about nutrition, sunlight, milk, some other thing, fruits, vegetables. So that means every single question I must go and look at one separate systematic review. But it's quick to do and quick to read. So narrow questions are easy to do. Broad questions, it take about 2 years to do a systematic review. But the advantage is, if somebody wants to know how to prevent TB, they can get all the answers from your review. I don't go to have to look at 5 different systematic reviews to see, oh, should I give milk, should I give food, should I give sunlight, should I do exercise, should I do social distancing, should I give economic, and free food, whatever, direct to home money, whatever it is. So broad reviews are good for policy makers, everything in one shot, difficult to do, right? So again, P stands for the participant, I the intervention, C stands for the comparison, and O stands for the outcome. So the speaker will haunt you everywhere in research, so we should just get used to that. It's really a worthwhile thing to do. It's free to do, but it's very worthwhile. So again, one more example. So these are some two treatments. Married women who have this candidiasis, and there is a treatment called Kundur, and there's an alternative which is allopathic, which is miconazole, and there's an outcome which are primary and some secondary outcomes. So if you specify each of the components in your systematic review, it becomes very easy when you search literature later on. Should I include this study? Should I not? I'm only interested in this comparison versus this comparison. I don't want anything else. So the PICO again is the beginning of your systematic review. So, right. The other thing, if you want to look at slightly different, if you want to look at what works for a particular stage of COVID, then you must specify that. The setting is also important. Are you looking at low income countries, moderate income countries, high income countries? So, are you looking at preventing mild COVID, moderate COVID, severe COVID? So it will be a little bit more specific when you write your P. What is exactly your question? Or you can say that it's a Siddha drug for any stage of COVID. So to be a little bit carefully writing your PICO statement, what stage of disease, what type of patient, which setting you're trying to address your question. Okay, now there are 3 steps to do in a systematic review. One is the review itself, how to do a systematic review. Secondly, you must understand the review process, how does that process happen, and lastly, publishing. So there are 8 steps. So there are 8 steps which are defining your systematic review questions, register your title, plan the review, publish your protocol, conduct the review, publish the review, and every 2 years improve and update your review, and then publish your updated review. So I'll just take 8 minutes to go through one step. So define the question I've already finished. One must define your PICO question and the study design. This is fairly easy. You need to know that. Just like doing a randomized control study, after doing an RCT, you may be interested in doing a systematic review of the same topic. Register your title. Now, if there are many organizations that do systematic review, you can register your title in Cochrane itself. An organization, you can say, I'm doing a Cochrane review. You can say, I don't want to ask who this Cochrane, why should I get permission from them? There's an open registration system called Prospero, Prospero, Prospero. So you can register your systematic review in Prospero. Again, like a randomized control trial, as Dr. Kant mentioned, if you don't have a clinical trial registry number, nobody will publish your RCT. Similarly, if you don't have either a Cochrane number or a Prospero registration number, very difficult to get your systematic review published. Because they say, how do we know? You just suddenly decided to pluck one out of the air without any planning. Having said that, there are some more organizations, one in Australia called Joanna Briggs Institute, and many other people are coming up and saying, why should we follow Cochrane or somebody else? So Australian people tend to follow Joanna Briggs, BRIGS Institute. They have their own system, ecosystem for doing systematic review. So that is registering your title. So who needs to be involved? Now, one of the rules of systematic review is it can't be I, me, and myself. A minimum of two people. Because you may make mistakes, I may make mistakes, but together we do all the process together. Everything which I'm mentioning now, I'm not going to keep on mentioning the same word, but everything is done in duplicate. What is done in duplicate? You're making your title, searching literature, assessing quality of studies, extracting data, analyzing data. Everything in a systematic review should be done in duplicate so that you can avoid errors. That's part of the systematic process. That's what makes it systematic. So you need to have two people at least. You must also involve consumers of your review. Who will be the consumers of your review? If Sulika is doing a review for some INC for maternal and child health, it may be the government officials. If they are part of the systematic review, once the systematic review comes, it automatically changes government policy. You may have, if you're doing HIV review, there are HIV patients groups. If you involve them, as soon as your review is over, they'll automatically become empowered. Hey, doctor, one review says this treatment is really good. So you need to involve your stakeholders while doing a systematic review. That's an important part of it. You need to have somebody who's an expert in doing systematic review. So one of the things that you should start off, let us all do systematic review, but you don't know what we are doing, then it will be a disaster. That is, one person should be an expert in doing the systematic review. So you need to share, this is a group of people from the Ayush group in Delhi who are doing systematic review. So there's also something called Cochrane review group. For example, there's a Cochrane pediatric group, Cochrane infectious disease group, Cochrane vaccine group, Cochrane renal group, cardiovascular group, gastroenterology group. You can contact those groups and say, see, I want to do this review in your area. Can you help me? And they may be more than willing to help you to do the work. But again, remember, they are volunteers. Nobody's paying them. So like you and me, they have to go back, do their work, take care of family, have some spare time. In that spare time, they're helping you for free. So you should not get angry. I emailed yesterday night, today morning, they didn't reply. We tend to, weekend, like so saying, if I send a mail to my students on Saturday, they may feel like, I better reply by Saturday night. But in the West, it's like, okay, Monday morning only. There's nothing on weekend working. I'm not making fun of weekend work, but you have to be a little patient with your mail because usually after this workshop, I get a lot of mail from the rest of people. So nobody's responding from Cochrane. 3 days over, nobody responds. Just wait for some time. They will think about it, then they will get you a reply. You can mail the Cochrane review group. I've already mentioned about consumer groups. You can also Google this Cochrane review group, consumer group, and also Cochrane consumer network. You can Google this. They have people like heart disease patients groups, HIV groups, cancer survivors groups. So those groups can help you if you can't find somebody in your local area who represents patients. So you have to have there's a health professional will help you with policy makers, consumers. They may tell you like, say, this question is not exactly correct. Why don't you change this question because if you don't think the outcome should be this, the comparison can change slightly. So you have to be a little bit prepared to be flexible in your PICO question. Because this is the PICO question, join if you like, because they're also part of your team. So they may have some ideas about modifying your PICO question. I'll give an example. One of my relatives had vitiligo. So he was like, the doctor says if your vitiligo will come down by 25%. So I'm not interested in 25%. I want this damn thing to go away. So exactly like that, the doctor thinks 50% is good. The patient thinks 100% is good. So then they'll say minimum clinically important difference is 75% in the Cochrane review. If vitiligo came down by 75% in any study, that is taken as the minimum clinically important difference. How did we come to that? Consensus between doctors and patients. So like that, quality of life, what score to use, how to judge quality of life or outcomes with adverse effects on quality of life, very important to involve patients. Okay. Now, what resources do you need? One resource which nobody talks about is time. You need to spend about, if you have a team of 4 people, on average, each of you will spend 1 hour a day for 1 year. So that sounds small, but if you actually think about it, 1 hour straight every day for 1 year, all 4 people to do this silly thing. So then you have to give that commitment of time. Somebody should have expertise, access to scientific literature, You need somebody who can get all the studies. I can identify 400 studies. Many of them will not be free. One of the rules of Cochrane is you cannot get it on Sci-Hub or through some pirate or some other wrong method. You have to get everything legally through a right method. So office technology, not much. Everybody has got laptop now, so office technology is not a big deal. So it takes about a medium of 30 months from the idea stage till completing a review. Medium. That means some groups are really fast. They'll be doing one review in 3 months. If you're doing for the first time, it may take 2 years. So you should not get frustrated. I thought I'll get this quickly for my promotion. Because I don't have to do an RCT. I'm correcting other people's RCT. Quick, let us do this. It won't be quick. It will be slow. So mentally, you have to be prepared for about a year and a half on a median. Now, if you plan to do a broad question, it will take more time because they've got many comparisons, lots of studies, complex. If you take a narrow question, it will finish faster. You have to also think what you're getting into. Can I do this? Do I really want to get into this broad area? Okay. Expertise, access to literature, I already told you about. You need to get statistical expert and a literature searching expert. Authors, usually there are about 5 authors. Generally, in Cochrane review, there's a median of 5. You can do it with 2 also, but the more people to help you, the better. So generally, you need around 5 people to help you. Software. Cochrane has a free software which you can Google called RevMan. You can Google it as RevMan 5.2.4. It's a free version. But now, UK government has withdrawn funding from Cochrane. So now they put the Cochrane software online, which you have to pay for. So the older version is 5.2.4. So versions after that, with all newer things, the software is on the net. You enter data on the net, it will give you the results that you can download. So that you have to pay for. It's not much. If you have a group of 5 people, you can pay and use the software. So this RevMan software, if you don't want, you can use a slightly older version. 99% of people in the world use RevMan software for the systematic review. They don't use Cochrane. It's a non-Cochrane review, but they use the software because it's very nice, easy to use. So all of you can download that one if you're interested. The other one is called Covidence. What does this Covidence software do? Let us say I search PubMed. I get 100 abstracts. I can just directly import those 100 abstracts from PubMed into this Covidence software. Let us say both of us are doing the review, or both of you doing the review. You will look at one abstract. You have your PICO next to you. You have to ask yourself only one question: include, exclude. 90% just reading the abstract, you can make out include, exclude. You don't have to do anything. The Covidence just put include, exclude, finish. He does the same thing, where both are independently, not sitting together. So when you both agree, there's no problem. When you both disagree, then you'll have a third person who will adjudicate the differences. And he's also looking at Covidence. He knows his only role is adjudication. Every now and then he adjudicates why the article should be done. Once the abstracts are done, you get a button in the Covidence. All abstracts green. Now you had 5,000 abstracts. You got 100 articles which you thought both of you agreed on. Like either both of you or 2 other people who decide. Now we have to get the full text of these 100 articles. You can import all 100 full text into Covidence software. And let us say both of you are screening. You will look at the full text and decide include, exclude. You will look at it. When you both agree, very good. When you don't agree, that a third person will adjudicate. So Covidence software is excellent for that because it's on the net and it will give you agreement statistics also. How often the 2 reviewers agree, disagree, and it will produce a nice figure which I'll show you in a second. After that, on the Covidence software itself, 2 other people, let us say, Sulika and you, both of you will decide, we are going to extract data. Now you have only 10 RCTs which you finally decided. Out of the 100 RCTs, only 10 you decided to include in your systematic review. You extract data on the main outcome, primary, secondary outcome. You extract separately and you can compare and see whether both of you extracted same. And from that Covidence software, you can export the results directly into the RevMan software. So it works, those 2 software works seamlessly. Now, of course, it will export directly into the online RevMan, not directly into your paper RevMan. You can export it into a file and import it. You can work around that. So this software is also paid. It is not very expensive. If you are saying I'm doing a single review, You can pay online for that. Until the review is over, you can use the COVID. So I would urge you to try the software. Now, there's something called grade of evidence. That is the quality of the evidence overall. Like Dr. Khan taught us about randomization, allocation, blinding, blah, blah, blah. All that together in systematic review language is called the grade of evidence. So there's a software which is free online. Currently it's free, called Grade Pro software. You have to just go online and register, and you can do the grading of the evidence online free. That information can be imported from the net onto your resonance software. So these are the other software which people use. There's another software which is the alternative to resonance called Epidemiology. Some people love this Epidemiology software. Again, you need some sort of software. You can't do it manually on Excel. Some people do everything on Excel, but not a great idea. And there's an editorial manager which is Cochrane's own in-house software. All right. So the first step, I told you there are 8 steps. The first step is to define your question, and I've spent enough time telling you about PICO. Step number 2 is to register your title, either in Cochrane or Prospero, Joanna Briggs, or somebody. Somebody has to register. If you can't find anyone to register, there are some other online free portals. OSF, correct, OSF. Open Science Foundation, OSF. That's an organization where you can save your online data by yourself. You can also register your systematic review, especially if other people refuse OSF, Open Science Foundation. You can register your systematic review there. So that's part 2. Planning your review, please have a group meeting of all the team members, because you have to decide, okay, you two are going to screen abstracts, you two are going to do full text, you two are going to extract data, you two are going to analyze data. What usually happens is the junior most person does everything, and everybody will be like, hey, what are you doing? So that won't work. You have to have a team and a timeline. Okay, this is going to take 1.5 years. So I know, okay, my screening of full text is going to happen only after abstract screening. So I can also check on the providers to see what stage they are. So I'll be thinking, okay, in a month's time, I'm going to have 1 hour a day for the next 1 month to screen full text. So that you have to commit that much time. So that planning is also a huge part. I told you about publishing your protocol in Prospero. Then you have to conduct the review. So the conduct of the review involves 4 stages: searching literature, all the literature possible, and I'll show you an example. What do I mean by all literature possible? Once you've decided the study is good, collecting the information from the study, because it's not, if you read randomized control studies, some of them are not very clearly published. Where's the mortality? It's in table 2. Where is the quality of life? It's somewhere given in the discussion section. So the outcomes are not beautifully the way you want it. It takes some effort to extract data from a paper. We extract, or not we, you must extract as intention to treat. So I think all of you understood intention to treat. The paper might have published it as per protocol, but you have to extract the data as intention to treat. So your results may look slightly different or vastly different from what is published online. So you have to be very, very careful when you extract data that you didn't make a mistake, because everybody in the world can see how you have extracted data. Study bias, I'll show you a picture of study bias, how it's assessed, and then analyzing and interpreting your results. Publishing your review in Cochrane, it's very easy, because on real time, the Cochrane editor is seeing what you're doing. As soon as you make mistakes, you keep on giving you comments. So it's not like a journal where you submit, accept, or reject it. Here on a continuous basis, you're getting feedback. So as soon as the work is done, it's ready for publication. If you do it in Prospero, once you're finished, it's your job to send it to a journal, then get send it to 2 reviewers or peer reviews, then it'll come back. So that's another big process by itself, and there's no timeline for that. Updating your review, just remember that you must update your systematic review as per your own knowledge of the evidence in your field. For example, in COVID, I told you, they had to update it every other week, because say, data is coming newly. But in your known area, if you know that no studies are coming, so every 2 years you can just do a new search and say, the review has been updated by search, no new studies. No new studies found and reviews updated. So generally, every 2 years minimum, you must rerun your search, but that is depending on your area. Okay, so now I want to show you one systematic review. Just to take you through the steps of one systematic review. This systematic review is looking at hyperimmune globulin for patients with COVID. I don't know if you remember, President Trump came and said, Regeneron, everybody must have Regeneron. So everybody in US wanted a jab of immunoglobulin. I think Kerala government gave everybody some, also some MABs and BABs free. I think. I'm just making fun of that. So hyperimmune globulin for COVID-19, a hot topic. So let us see how they went about it. And I'm going to skip a bit. So if you have epilepsy, just forgive me because it's going to be a bit hot. Okay. When you start a systematic review, the first topic will always be describe the condition. So you need to give the reader an idea why should you study COVID? What's the importance of this particular topic? Not the intervention, the disease. So the first heading is always describe the condition. The second topic is describe the intervention. So what is this hyperimmune globulin? So you have to have some literature references on it. What is hyperimmune globulin? The next heading, how it might work. So you give a lot of literature on the biochemistry, pharmacokinetics, pharmacogenomics, pharmacotherapeutic, whatever pharmaco blah blah of hyperimmune globulin. Then the mechanism of action. What is the mechanism of action? How this immunoglobulin might work in patients with COVID. You can give some explanation. Then last question, why is it important to do this review? Okay, this is a policy important question. Nowadays there are hundreds of systematic review on any topic. Do we really need one more systematic review? Why should you do this? So you have to give an explanation. Then comes the method section. The types of studies. Are you going to use randomized control studies, quasi-randomized studies, cohort studies, before-after studies, IPS studies? Why you're going to use it or why you're not going to use it? We'll give an explanation of the types of studies. Then, what types of participants? The P. You want only children, adults, men, women, ethnicity. What is the situation of these participants? A few lines. Then the I. What does, in your view, immunoglobulin mean? So because each person will have published differently in their studies. What all are you accepting as immunoglobulin? So you have to give some explanation of what is that. Then very similar to what you're doing right now, what are your outcomes for your systematic review? What are your primary outcomes? And then what are your secondary outcomes? Harm outcomes and the timing of the outcome. So very important, timing of the outcome, what Dr. Kant mentioned. Is it immediate, 1 month later, 6 months later? The timing of the outcome is also important. The next thing is where all you're going to search. How do you search literature? So at the minimum, one needs to search Medline, which we all do in India. M-based, Encyclopedia Medica or slang European medical database, you have to pay money to search. So many people cut and paste Cochrane methodology from another review. Okay, very nice. Let me say I'm going to do all this. In that they'll cut and paste M-based. Finally, then I don't have access to M-based, but in the protocol you already published, I'm going to search M-based. So be careful when you cut and paste somebody else's methodology and say, I'm going to follow all that. Next, you can search COVID registers, WHO itself. Epidemiology is a sort of website. It was previously separate from COVID, from Cochrane. Now this database is part of Cochrane itself. And you can search the Cochrane register. How do you search for clinical trials ongoing in India? Anybody? How do you search for ongoing clinical trials in Zambia? How can anyone search all registries of all countries? So WHO has got a clinical trial registry. It is called a secondary registry. So you go in International Clinical Trial Registry Portal, ICTRP. You can go there and if you put your search term, any country in the world with an ongoing study, you can find out. And then tell you the study is already ongoing, completed, published. So ongoing trials, completed but not published, you can put it in your systematic review and say, hey, we know that there are 15 trials coming up. and then the next update will tell you the results of those 15 studies. So you have to do a deep search of literature. Okay, then how are you going to collect the data? Are you going to use a software? So these people have used covidence software. And then how are you going to synthesize the data? So you give a little bit of information. They are using the RevMan software. And are you going to do subgroup analysis? Yeah, we're going to look at people with mild, moderate, severe COVID, young people, old people. So just like you're doing a randomized control study analysis method, you must give a analysis methodology. Sensitivity analysis is something you can't plan for in the beginning. High quality studies you may look at separately from low quality studies. Instead of quality, we use the word risk of bias. High risk studies may be taken out in the analysis and looked at separately for low quality studies. Okay, so now this diagram is called a Prisma flow diagram. So what did they do? They found 21,000 studies abstracts. 21,000 abstracts. So all of you want to jump into this, just think about it. After finding 21,000 abstracts, two people looked at all 21,000 abstracts and excluded 20,000 abstracts. So this will take about 3-4 months or 6 months. If you have it offline and doing one by one and then comparing, it's a huge task. Excel spreadsheet, I do 21,000 studies in an abstract Excel spreadsheet. You do 21,000. Then we merge the two Excel spreadsheets and do take a long time. That's why this covidence is useful. Then they got 825 full text. Can you imagine if both of you had to screen 825 full text articles? And that you can't do fast. You have to go through that article carefully. That will take you, a long time, okay, minimum. After screening 825, only 17 studies were included in the systematic review. This is called a Prisma flow diagram. All systematic reviews will have a similar picture. Huge number of abstracts, a smaller number of full text screens, a very small number of final studies included. So this is how a systematic review picture goes on. Now I'm just going to skip a bit because I've already seen this before and I want to show you a picture, not a picture. From every single study, what information is taken. So I just finished a few minutes, so bear with me, it's a bit late today. Ali 2021 is the surname. The first author's surname is Ali. The study was published in 2021. From every single study, this is the information they had to extract. So after the full text screening for the 17 studies, two other people, let's say Tulika and a colleague from Assam, they had to extract the data individually from each study. What is the study design, the journal name, recruitment date, the country, what language it was, how many centers, the clinical trial number, date of registry of the clinical trial, then the age of participants, number allocated, severity, comorbidity, inclusion, exclusion criteria, how IVIG was made, and the primary outcomes of the study, secondary outcome of the study, sponsor of the study. All this information has to be collected apart from the outcome. So it's a large part. You have to sit a long time, collect so much information from each paper. That's why this online software will collect much of this information directly for you. Otherwise, each of this data on Excel spreadsheet, you have to collect from each of those papers. So like this, there are 17 tables from 17 studies. A lot of work, right? Now I'm just going to show you one more table. So you also have to tell, there are so many studies they excluded. Remember I told you 825 RCTs, they excluded about 800 of them. Once you got an RCT, you have to tell the reader, hey, why did you exclude 800 RCTs? So for each of those 800 RCTs, you have to give a reason for exclusion. This study is prophylaxis only. Patients with current or prior COVID were excluded. So they decided to exclude them. So you have to give a table of 800 studies, why you excluded them. Again, being thorough, being systematic. So when you say systematic review, this is a systematic part of it. Okay, let's cut to the chase. Let's look at the results. Uh, when you look at the quality of a study or risk of study, was the randomization done well? Exactly what we learned today. Allocation, risk blinding, loss to follow-up, selective reporting. Green means done well. Red means done terribly. Yellow means generally we can't make out from the paper because they didn't write anything. And if you write to the author, they didn't reply. Generally it means they didn't do it, but sometimes authors don't reply. So that's yellow. So if you look at this paper, this study is ITAC 2022. Well done randomization. There were no deviation from intended intervention. There's no outcome missing data. The outcome measurement was blinded. There's no selective reporting. Overall, very well done. So for every single 17 study, for each outcome you're assessing, you have to do this risk of bias assessment. So if you have many outcomes and you have many studies, you can look at the number of outcomes for which you have to do a risk of bias assessment. So you really want to know garbage in, garbage out. So you don't want to get 17 garbage studies and produce a garbage systematic review. So very important that the 17 studies are good quality studies. Yep, yep, yep. Okay, now let's look at some pictures. One picture. This picture is the final outcome. So this is to give immunoglobulin. This is relative risk. On a relative risk scale, relative risk of 1 means no difference between treatment and comparison. It's not zero. When you're looking at the difference in weight, difference in mean height or BMI, then the difference is zero. Relative risk, odds ratio, hazard ratio, 1 means no difference. So this is a study, ITAC 2022. The outcome was mortality. There was only one study looking at mortality. It had about 300 patients getting immunoglobulin, roughly 300 patients on placebo, and the study was a high quality study. The final odds risk ratio was 0.79, suggesting protection, but the confidence interval was 0.43, again suggesting protection. On the other end of the confidence interval was 1.44, suggesting there could be some harm. So this is how results are presented pictorially in a systematic review, right? Is that okay? This didn't have too many studies in each comparison, so I'm going to skip to policymakers will not have time to look at 500 pages of a systematic review, but they will want everything in one shot. Give me a one-page paragraph of this. So what is that one-page picture of a systematic review? That's called a summary of findings table. So I just want to show you the summary of findings table. I'll just show you one table. Give me some time to get there. Okay. This is called a summary of findings table. So I'll just take you through one. Patients are patients with moderate to severe COVID. Inpatients. Intervention is immunoglobulin. Comparison is placebo, which was saline. The outcome was all-cause mortality. If you don't give IV immunoglobulin, 77 per thousand will die. If you give immunoglobulin, 61 per thousand will die. So that any policymaker can understand. You don't have to understand relative risk, odds ratio. We also may struggle. Oh, that's relative risk of 0.79, but the confidence interval causes 1. This was a single RCT of 579 patients. Overall grade of evidence they put low. But if you remember previously, I said everything was green. Let us explain that to you. So, what do they mean that if it was all high quality, why did they say overall quality of evidence low? If you see there, they put a small a next to that. And at the bottom of the table, certainty of the evidence was downgraded twice for imprecision because of wide confidence interval or imprecision and because the results are based on a single small study. So even though it's a high quality from a single study, globally, if you're going to make a recommendation, we're not so comfortable, so these are the quality of the evidence. You may not agree, you may agree, but they put everything up there for you to see. The last thing which I just want to show you is a summary of findings table, or sorry, a picture from another systematic review. This is neonates or small babies, if they have hypoglycemia, they can have severe complications. So this systematic review looked at a dextrose gel versus no gel for small children with hypoglycemia. This first study, Hegarty, is done in published in 2016. The second study, Harding, was 2021, and the outcome was neurological disability at 2 years of age. You can see a strange thing. Hegarty et al. Found that dextrose gel, you see, this is the point estimate. People ask me what is point estimate. The point estimate is 0.21, suggesting nearly 80% protection. This is the confidence interval. Even the lower limit of the confidence interval, which is here, 0.78, suggests about 22% protection, relative protection. But the other study by Harding, actually the point estimate suggests that there is harm. How can that be? Even though the confidence interval crosses 1. And the summary of these two studies, mathematically, if you summarize these two together, that is this, showing no difference. The diamond is the summary. This is called meta-analysis. When you take 2 or 3 studies together and you combine the results mathematically, it's called meta-analysis. The whole process I described till now is called systematic review. After doing a systematic review, then if you combine the numbers, it is meta-analysis. You know what other people will do? Hey, I got 4 studies which say drug A is better than B. I'll simply combine all 4 and say it is systematic review. A is better than B. I forgot to tell you there are 20 studies which show no difference, and another 20 which say B is better than A. That's why you should be very careful when people say I did systematic review, I did meta-analysis. Hey, what is your PICO? Where's your search strategy? What is the quality of assessment? Were there 2 people? How did you extract data? Oh, that and all we didn't do. Don't ask all silly questions. So that's the problem. So, is this homogeneous or heterogeneous result? Everybody is really sleepy. Heterogeneous. So, can you capture heterogeneity in a particular way? So, there are a couple of statistics here. This chi-square is the one which, and Dr. J was talking about chi-square. I could some of you looking very, so I did medicine because I didn't like math. So chi-square statistics tells you to interpret chi-square with degrees of freedom and then the p-value. So the p-value suggests there is significant heterogeneity, but then you must understand chi-square. So there is another statistic called I-square. I mean, the trick. I-square statistics is here. Can you see I-square? A simple rule of thumb. People don't agree with this. I-squared statistics less than 25% suggest very little heterogeneity. All the studies are saying the same thing. Then you're happy. There's no study saying this is different thing. 25 to 50% moderate heterogeneity. More than 50% significant heterogeneity. Be very careful when you interpret the final result. How can you combine a short man and tall man and say most Indians are average height? It doesn't make any sense. This is like that. So here we have to be very careful and say, hey, how come Hegarty found this? How come Harding found this? So one can try to explain, as Dr. Kant was mentioning, when you get results, you have to be willing to explain the results. How can you explain the results? Sir, even though we took PICO very carefully, Harding had slightly older people, Hegarty had slightly younger people. The immunoglobulin used by Harding was 3 days old. Harding, the other fellow used it immediately, freshly prepared. So that might explain the 2 differences. There was some statistical methodology difference between these 2. Either the PICO was different, or the statistical methods were different, or some other society was different, poor people, rich people. You have to explain that. This is an explanation, verbal explanation. You know, in a random or in a cohort study, if there are baseline differences, how do you get over that? Regression analysis, logistic regression, linear regression. Like that, one can also do a regression analysis to explain these differences. That in a systematic review, that is called meta regression. Can you explain differences statistically? Age explains the difference, or maybe diabetes explains this difference. So you can do meta regression as well. Once you've published this, then you write a discussion. What does this result mean? You never conclude a Cochrane review. This is the last point to make. You must all give IV immunoglobulin, or you must never give. Don't follow people who say. Don't say that. This is what the data says. It is for a guideline developer. It is for the patient. It is for the doctor to make up their mind whether they want to use or not. So generally, people like to say, Eureka, I found out everybody must do this. So generally in Cochrane, they advise against saying that just present the evidence, the benefits, the harm. There's another table for harms of IV immunoglobulin. Usually you find that side effects are very small in most small RCTs. But you can even look at primary harms in systematic review and publish that. So that's also very important to give a balanced story. And every 2 years you have to update your systematic review. I know I've taken a rush through of systematic review. 5 minutes for questions. Just let us go there. Most important question. How can I run out from here? Yes.
Bias towards publishing only positive outcomes. And,
I don't know whether this study had a picture like that.
sometimes negative publications don't even come to published literature.
I don't know. Have you all taken down this? You all know what you're supposed to do tomorrow? Now about this? Then you won't do anything tomorrow. So I just rub off from this side. I'll just show you this last thing. I keep saying last thing, last thing. So you have to produce a figure which looks like this. Maybe this is the relative risk or the odds ratio. And these are individual studies. And on this side is the sample size. This is large sample size. This is small sample size. Actually, it's not sample size. It is standard error. And you know that the smaller standard error will be here, larger standard error will be here. But you can take it to imagine sample size. You will find that this is the summary odds ratio. Whatever the summary, 1.5 was the summary relative risk. You will find small studies less than 1.5, small studies more than 1.5. You will find large studies less than 1.5, large studies more than 1.5. So it generally should be a sort of a funnel shaped Christmas tree or a Ashoka tree kind of picture. If you see this picture, you will say there is no publication bias. Even unpublished small, everything I have managed to pick up. What you'll usually find is that you'll find some area, let's say like this, you'll find something missing. That means there was publication bias. Small studies not favoring the intervention never got published. They must have been done. But either the author decided, bad luck, how come I went down this road? He himself junked it, or his boss told him forget it, or no journal was willing to accept it. So somewhere along the way it got finished. That's why we must search for clinical trial registry. Only then you will find out. Sometimes you can contact pharma companies for their own material. They may not be very happy to give you their own. They'll have a file on every drug. In Western countries, you can get it legally. Again, there's a controversial Cochrane review on oseltamivir. You heard about the Tamiflu. So the initial systematic review said Tamiflu very good for influenza. And this reviewer, Goldacre, he went and got all the pharma company trial reports. Finally found oseltamivir doesn't reduce mortality or morbidity. It reduces fever by half a day. So everybody got very angry. Oh, this nonsense fellow. By that time, true story. All countries in the world have spent billions of dollars in stocking up Tamiflu. Right? So you have to be a bit careful about this publication bias. There are other stories to tell, but maybe not today. Just, always think dots therapy is good. If I have TB, should he come every day and say take the tablet? How many say yes? Some government in India think it's good. What is this big question at 6 o'clock? You all heard of dots therapy? Is it good? But nobody putting up the hand. Okay, so I did put up the hand. Okay. If you Google Cochrane library right now, you'll find that there's a Cochrane review found that the actual direct observed therapy has no benefit. But all countries in the world have invested so much money to make sure that every TB patient for a doctor provider will go home, put the tablet in his mouth, put water, make him swallow and go. Of course, this is a theory, whether it happens or not, but so it's quite controversial when you get into this area. You may run into problems. And then they say, this evidence-based idiots made us spend so much money. Now they're saying it doesn't work. So you have to be a bit careful about how one does these things. Yeah. Okay. Thanks very much for your time.